Patrick Serruys, interventional cardiologist, affiliated to the Imperial College in London. And this is what I have learned from the Syntax 3 trial, which is a tailor-made decision-making for surgical of percutaneous revascularization based on non-invasive imaging and comorbidity. So a couple of years ago, with Frederick Moore, we published a paper on the anatomical and clinical characteristic to guide decision-making between coronary artery bypass surgery and percutaneous coronary intervention for individual patient. I insist on that, individual patient. And that was the development and the validation Syntax score 2. The Syntax score 2 variable has been established based on interaction and applying a Cox proportional hazard model. And the model predict the 4 years all-cause mortality with a combination of clinical and anatomical independent predictors of these 4 years all-cause mortality. And you see we have the classical anatomical Syntax score, the presence of the left main, the age, the creatinine clearance, the ejection fraction, the gender, the peripheral vascular disease, and the chronic obstructive pulmonary disease. And with these 8 parameters introduced in the calculator of the website, you put the Syntax score, the age, etc., the ejection fraction, and you get a score, the Syntax score 2. And that Syntax score 2 on the left-hand side of the slide will tell you what is the probability, the predictive probability of 4 years mortality. So this is an example of the Syntax score 2, where the PCI 4 years mortality will be 15%, while the cabbage 4 years mortality will be 4.2%, and the treatment recommendation is very strong. This patient should be sent to surgery. But you can have a PCI 4 years mortality based on the Syntax score 2 with 10.5% and cabbage 9.9%. Then the treatment recommendation will be cabbage or PCI, since there is equipoise for 4 years mortality. In the last case, because the patient is elderly with COPD and so on, the cabbage 4 years mortality is very high, 42.7%, while the PCI's mortality based on the Syntax score 2 model is only 10%. Therefore, the recommendation in that case will be PCI only. So the Syntax 3 trial sought to determine the agreement between two heart teams on treatment recommendation based either on coronary CTA, coronary multi-slice CT scan angiography, or conventional angiography in patients with left main or three-vessel coronary artery disease. So we had initially a population known with three-vessel disease with and without left main conventional angiography. 223 of these patients were eligible. They have to undergo a multi-slice CT scan with the GE Revolution of GE company, and then the patient was randomized between two heart teams. We did not randomize the patient, we randomized the heart team. And the first heart team A, was receiving the angiography alone, while the heart team B was receiving the multi-slide CT scan. And you see here some of the surgeons who have helped us. You see the heart team with the three components, the interventional cardiologist, for instance, Antonio Bartorelli, the radiologist, Daniele Andreini, and the surgeon, Giulio Pompilio. We had 6 centers in Europe, in Monzino, Italy, Brussels, Belgium, Zurich, Switzerland, Nancy, and the Centre Cardiologique du Nord in France, and the University Hospital of Vienna with the surgeon Thorsten Dunst. Now, the our team B received the multi-slide CT scan alone. And what it has to do with that is to define the anatomic syntax score derived from the multi-slide CT scan, combine that with the comorbidities to build up a syntax score 2. The primary endpoint of the study was the agreement on the decision treatment and the treatment strategy between the heart team receiving the multi-slide CT scan and the heart team receiving only the conventional cine angiography. And that heart team A has to do the same exercise based on the conventional cine angiography. They have to build up the anatomic syntax score combined with the comorbidities and clinical characteristics to come up with the syntax score 2. And the primary endpoint was the agreement between these two heart teams. Now, for the heart team receiving the multi-slide CT scan, the heart team B in this case, there was a second level of decision making, this time based on the fractional flow reserve derived from the multi-slide CT scan. So what you get there is the functional physiological significance of the lesion. We call that functional anatomic syntax score. So that heart team B had finally the anatomy, the physiology, and the comorbidities, and that was the second level of decision making. Now, this is a virtual trial, so at the end we were we unblinded the two heart team, and they had the three information at their disposal: the angio, the multi-slide CT scan, and the FFRCT. I have to tell you that this center was working specifically with the multi-slide CT scan of GE, General Electric, the Revolution CT. Why? Because it's one of the most performing multi-slide CT scan with a very large detectors of 160 millimeter. You can catch the whole heart in one step. There is no stitching procedure with part 1 and part 2 of the heart. No, the whole heart is caught in the analysis in one time. It's one of the multi-slide CT scan with the highest temporal resolution, 140 milliseconds, and there is also a software to even improve that temporal resolution, and it's the best in class for spatial resolution, 0.23 millimeter. It's very close to cornea angiography. Now, the work to be done by the heart team is to assess the severity and extension of the coronary artery disease using the multi-slide CT scan or the cornea angiography. More than 50% was the criteria. Then, in the case of the heart team B, The FFRCT, the fractional flow reserve derived from the CT, was used to calculate the non-invasive functional syntax score, which was computed by subtracting these lesions from the anatomic syntax score. So you end up with only lesions that are physiologically significant. And then at the end, what you have is the new syntax score 3, which is conceptually a combination of coronary anatomical complexity with its physiological repercussion and combined with the patient clinical characteristic and comorbidity. This slide showed the data flow coming from the different centers, coming to the academic core lab in Rotterdam, and from there we were analyzing the anatomy during the day, and then by night we were, by telemedicine, putting the multi-slice CT scan on the cloud in the middle of the Atlantic and transferring the multi-slice CT scan to the headquarters of HeartFlow in California, where during our night and during their daylight working days, they were analyzing the FFRCT and forwarding back the FFRCT to Rotterdam. So basically the objective of this trial was the agreement between the two heart teams on treatment recommendation, and the primary endpoint was based on the anatomical assessment assessed by Cohen-Kappa between 0.6 and 0.8. We would be very happy about the agreement. Secondary endpoint was the impact of FFRCT on treatment decision and planning. Now, every Wednesday at 6:30, we had the same identical format of presentation to the surgeon, the interventional cardiologist, and the surgeon. And you see an example here of the clinical characteristic with the creatinine clearance, with the ejection fraction, with the risk factors. And then basically we were blinding one heart team and then providing the other heart team with the computer tomography angiography, in this case obtained with 50 ml of contrast with radiation dose of 0.9 millisievert. And the first presentation was the so-called maximum intensity projection. You can appreciate the long narrowing here in the LED. There is no problem in the ostium of the first and second diagonal. You see a very short main stem. The circumflex here is divided between the posterolateral branch and the circumflex itself, and there is a bifurcation with a Medina 111. You could see that there is intermediate lesion in the proximal right coronary artery, and there is a nodule of calcium. We will see that better here, a nodule of calcium at the ostium of the right coronary artery. If you look at the calcification of the aorta, you have to be prudent with any manipulation of the aorta by the surgeon. This is how we present the data to the surgeon. This is the right coronary artery. You can appreciate the nodule of calcium at the ostium, the lesion in the proximal part. If you look more distal, you can appreciate the bifurcation between the PD, between the posterolateral branch. So we score basically 3 points for the ostium, like in the classical anatomical syntax score, and 1 point for the proximal lesion in the right. In the LED, you can appreciate this long lesion in the mid part of the LED. Obviously, this is a disease segment. The distal bed here, the landing zone, is quite healthy, but this is quite a disease. There is calcification, but you surgeon does not care too much about that. So because it's a long segment of more than 20 millimeter, and because it is in segment 7, we got 6 points for this lesion. Now, if we go to the circumflex, it's clear that we have there severe bifurcation with Medina 111. That's with 70 degrees between the two legs. So finally, we give 8 points for this lesion. So if you look at the multi-slide CT scan derived syntax score, 3 points for the right, 2 points for the proximal right, 5 points for the LED mid, because it's a long lesion, 6 points, circumflex 8 points, in total 24 points. Then we give to the heart team B the functional syntax score FFRCT. You can see immediately that the LED has an FFRCT of less than 0.8. If we go more in detail for the right, we were surprised by the fact that the FFRCT just before the bifurcation here is 0.85, non-significant. There is a small drop at the ostium, there is a small drop in the proximal path, but you remain above the level of 0.8. So we have basically to remove the right coronary artery from our anatomic assessment. The LED confirmed these 7 points for the LED, but the ostium of the two diagonal is okay. As far as the circumflex is concerned, the physiological significance of the circumflex and obtuse marginal is confirmed with 8 points. So at the end of the day, the only point that we have to remove is for the outer ostial lesion, remove 3 points, and the proximal right. And we end up with a functional syntax score of 19 points. The next step is to put that in the computer. 19 functional syntax score, the age, creatinine clearance, ejection fraction, left main, gender, COPD, PVD, and the PCI 4 years mortality is 13.6. The CABG 4 years mortality is 11.6. So basically equipoise between the two treatment. And in Monzino, they decide to put one Lima on the LED and still one saphenous vein graft on the obtuse marginal. Now, the group of Monzino this time is blinded for the conventional cine angiography that you are going to see in a minute. The injection of the right coronary artery, if you look carefully, the guiding catheter of the diagnostic catheters, there is a backflow, so it's not a very severe ostium lesion if there is an ostium lesion, and the proximal part of the right coronary artery nevertheless was scored with 2 points. The LED is indeed initially a selective injection in the circumflex. Finally, you get the LED fill in, and indeed there is a long segment here which is disease. So they give 7 points considering the length of the lesion. And the circumflex confirmed the bifurcation with what we call in our jargon a Medina 111. So it's really a kind of Mercedes type of bifurcation, disease bifurcation, and you have to give an 11 point for these bifurcation with more than 20 millimeters. So from the angio, RCA 2 point, LED 7 point, Surg 11 point, altogether 20 point, and with these 20 point plus the clinical characteristic, we end up also with 13.9% of 4 years mortality for PCI and 11.6% for cabbage 4 years mortality. Equipoise in Brussels, they go after a treatment which is at the time of bypass surgery, a lima and a saphenous vein graft. So now I'm finishing very quickly by the result. Our goal was to have a Cohen kappa of superior to 0.60. The next slide shows you more or less that the anatomy by multi-slide CT scan was feasible in all but one patient. So in 22 patients, FFRCT has a yield which is a little bit less, 196 patients could have in all their lesion analyzed by FFRCT, but not 100%. The next is showing you the baseline characteristic of the patient. It's not the patient who is randomized, it's the doctors, but you could see it was a quite severe population with previous stroke, 8.1%, previous myocardial infarction, very low since the type of recruitment based on patient not yet revascularized by any means, including PCI. COPD 13%, peripheral vascular disease 17.5%. The mode of recruitment is a little bit peculiar in these trials since silent ischemia is an important component, 42.2%. These patients sometimes were diagnosed by a multi-slide CT scan in the first place. In terms of anatomy, as you could see, the anatomical syntax score on top there, 33.9 in the ARC team based on CT, a multi-slide CT scan versus 30.3 based on conventional angiography. This is a significant difference with a p-value. Originate partially by the tortuosity, which is much more correctly evaluated with the multi-slide CT scan, and also the difference in the assessment of AV calcification. The next slide is This slide is very important. It shows on the right-hand side the anatomical syntax score. On the vertical axis, you have the anatomical syntax score derived from multi-slide CT scan, and the horizontal axis. In the horizontal axis, you have the syntax score, anatomical syntax score derived from conventional cine angiography. As you could see, the coefficient of correlation is reasonable, 0.59 with a p-value of 0.001, but there is an intercept and the slope is not equal to 1. It's a reasonable biological relationship, but not exceptional. If you look at the blunt Altman, there is a systematic error of 3.6 between the syntax score, multi-slide CT scan, and angiography with quite large boundaries of agreement. But if you introduce the component of the syntax score 2, the gender, the age, the renal function, the COPD, the peripheral vascular disease, the left ventricular ejection fraction, and the presence of left main, as well as the anatomical syntax score, then the relationship became quite spectacular, with a very high coefficient of correlation, with a slope close to 1 and basically no intercept. And if you look at the blunt outman, then you realize that the systematic error is only 0.49, less than 0.5, with a limit of agreement which are around 5. This is quite exceptional. So this is one of the final slides, very important. On the horizontal axis, you have the heart team treatment recommendation based on coronary computer tomography. And on the vertical axis, you have the heart team treatment recommendation based on conventional angiography. And you see agreement for bypass surgery and bypass surgery only as an option of treatment. There is an agreement in 52 cases, 23.4%. The agreement between PCI of Equipoise, Cabbage, and PCI is about 69.4%. So the global agreement between the two heart team is 93%, which in terms of statistic, Cohen's kappa is a Cohen's kappa of 0.82 with a 95% confidence of 0.73 or 0.91. If you look at the language, the statistical language used by the Cohen's kappa, 0.6, 0.8 is a substantial agreement. Above 0.8, they are talking about almost perfect agreement. And then you see that the heart team agree also on the coronary segment to be revascularized in 81% of the case. The fractional flow reserve derived from computed tomography and angiography was available in a high percentage of lesion. The mean value was 0.63, and the fractional flow reserve derived from CT changed the treatment decision in 7% of the patient. In 13 patients, the surgical procedure was changed to a percutaneous approach. And on this final slide, you see that sometimes there was a reclassification here in 9, 8, and 13 patients. They were moved from a severe anatomic classification to a less severe anatomic syntax classification, and only in 3 cases there was aggravation of the anatomic syntax score. So 15%, 30 on 194 of the lesion of the patient were reclassified, and the patient were reclassified to a lower syntax score tercile, whereas 3 patients were reclassified to a higher syntax score tercile. Of course, there are limitations. This is really a premiere. We have the women are underrepresented. The patient with low ejection fraction, patient with unstable clinical are underrepresented. This is a virtual trial. We don't address the safety and the real feasibility of this approach, and we need an outcome trial. But in conclusion, in patients with left main of 3-vessel coronary artery disease, a heart team treatment decision making based on coronary CTA show an almost perfect agreement with the decision derived from conventional corneal angiography, suggesting the potential feasibility of a treatment decision-making and planning based solely on this non-invasive imaging modality. I think it's opened a door. We are going to do a first in man in which 6 surgeons have agreed to work on the multi-slice CT scan assessment alone, being not exposed to the conventional angiography, and proving the feasibility, the real feasibility of this approach. And of course, the safety has to be assessed and will be assessed by a new multi-slice CT scan 1 month after surgery to assess the patency of the bypass graft. That trial may be open a new avenue of research, open new avenues of research. Maybe we are entering a new era where the radiologist may have a more important role in helping the surgeon to define if the patient can be operated only on the multi-slice CT scan. I must say it is the surgeon during this trial, during this weekly meeting and Webex, it is the surgeon who have advised to make a feasibility first in man trial, which would be called cabbage evolution. Thank you very much.